Okay, our next speaker is David Miller from the University of Michigan, who will be talking on the science and intended use of robotic surgery. Thank you for joining us.
Thank you. Thanks very much for having me. It's an honor to be part of this session and to discuss some of these very nuanced and complex issues. I'm a urologist at the University of Michigan, and obviously urology has a big footprint in the area of robotics, perhaps as evidenced by the fact that there are at least 4 urologists involved in this program. So we definitely have representation here. In terms of disclosures, I do have funding from the National Cancer Institute, and I also serve as the director of 2 statewide quality improvement collaboratives in Michigan funded by Blue Cross Blue Shield of Michigan. And I should also probably disclose that I am a robotic surgeon. The vast majority of my clinical practice involves taking care of patients with prostate and kidney cancer and doing surgery robotically. So Dr. Whalen just finished his talk on pure standard laparoscopy, and I really tip my hat to him because technically it is a very difficult thing to operate on large organs in small spaces using the equivalent of basically chopsticks. And this is a paper that we published in JAMA back in 2006 that really represents the challenge that surgeons faced in terms of trying to get more minimally invasive procedures to more patients. And what was seen was that in 2 of the curves, you saw this typical rapid diffusion, almost the sigmoid-shaped curve for cholecystectomy and fundoplication for patients who had acid reflux disease. These are operations that were kind of immediately accessible to surgeons in the upper abdomen. They're common, so there was enough clinical material to get good at the operation. But the challenge was there were a whole host of other conditions, including nephrectomy for cancer, which is shown in the black box at the bottom, that were beneficial for patients. There was lots of evidence that doing a laparoscopic approach to kidney surgery in the donor nephrectomy population, for instance, was associated with a shorter length of stay, an early recovery, less pain medication, all the things we want to offer for our patients when they're going through surgery. The problem is these are really hard operations. You're moving from operating on the gallbladder, which is immediately accessible as you enter the abdomen, to operating on the kidney, which requires mobilization of the colon and a series of dissections around major blood vessels. So there was a big challenge in getting these services to more and more patients outside of a few artisanal centers where there were some really experienced surgeons doing these operations. So the question is, how do you move this from an artisanal scale to more of a production scale in terms of accessibility to minimally invasive surgery? And that's what we're talking a little bit about today. What is the role of advanced technology in offering greater access to minimally invasive procedures for patients with cancer? And you could say that at that time along came the robot. And this is what we'll be talking about today is specifically the Da Vinci system for robotic-assisted laparoscopic surgery. And Dr. Whalen laid out some of the proposed benefits of the robot from a technological perspective. And I would say that the 2 main ones that I see as a surgeon are better visualization. There is 3D high-resolution vision of the tissues you're operating on. If you stand in an operating room and are next to the robot at the bedside, and you look up at the screen at a standard laparoscopic screen, and then you move over and sit in the console and look in the 3D glasses, it's fundamentally different what you see. It's fundamentally different in terms of the depth of vision you see with the tissue, in terms of the clarity of the structures, and I personally believe that makes a difference in my ability to do the operation. So the robot was cleared by the FDA. That's different than approved. It was cleared by the FDA for general laparoscopic procedures. And why is it beneficial? Well, unlike our colleagues in radiation oncology, I don't have beautiful planning images to show, but I do think that a picture is worth 1,000 words here. And I have 2 short videos that Patrick promised me he's going to be able to play. First, both of these are for the vesicourethral anastomosis in a patient undergoing prostate cancer surgery. The first by a very experienced standard laparoscopic surgeon. Can you put that on the full screen by any chance? Try it one more time. If it doesn't work, we'll just do it on this screen. What I want you to just notice is the visualization of the tissues and then the difficulty with removing the needle from the bladder there and how you almost have to, even the most experienced laparoscopic surgeon, there's a little bit of pull and tension on the tissue. And this is extraordinarily hard to do. Extraordinarily hard to do. I've been involved in both purely laparoscopic and robotic cases. So think of that, how the wrist can only rotate, can only move in a couple of dimensions. And now let's contrast this to robotics in the next slide. And what I want you to pay particular attention to is as the needle comes out of the urethra on the second bite, watch the rotation of the wrist and try to get a sense of the better clarity of the tissue. So there's a very 3D visualization. This is a suture, a bite going in the bladder here. Now watch as this next bite, you can use both hands pretty easily. Watch the next bite after it goes into the urethra. Switch hands, left hand is used to drive the needle through. Now watch the right hand and the rotation of the wrist, because this is really some of the crux of the robotic. See how it can rotate it all the way back and then bring the needle out through the tissue pretty atraumatically. So I don't want to spend the whole time with fascinating videos, but those pictures I think are worth 1,000 words in terms of what the robot offers from a technical perspective, the visualization, the ability to have this wristed instrumentation. So what happened was, and we've seen this figure before, I borrowed this particular slide from Daniil Makarov, who's at New York University. What happened was there was a desire to bring minimally invasive surgery to a larger number of patients. The robot served as a potential tool to do that. In 2001, it was approved for robotic prostatectomy, and after that, things were off to the races. We saw these figures through 2008. So at this point, the infrastructure for expanding access to minimally invasive surgery had grown across the country. And this translated as well to the patient level. These are data from a study published in 2013 from Hopkins in the Journal of Healthcare Quality, basically showing the number of cases performed robotically in the United States and internationally. And I think this figure highlights, again, some of those real differences that exist in the US and our healthcare system and in other countries in terms of the adoption of new technology, almost this exponential growth in the frequency of these cases. And this adoption has been sustained. In the state of Michigan, I run a statewide collaborative that includes 42 practices, big and small, urban and rural, where we collect registry data for more than 90% of the urologists in the state. And what this figure shows is the relative proportion of robotic versus open prostatectomies in Michigan from 2012 through the second quarter of 2015. Fully 90% of robotic prostatectomies in the state of Michigan are now done robotically. When you look at the individual surgeon level, this is 111 surgeons who performed collectively 3,730 robotic prostatectomies. The robotic cases are shown in red, the open cases are shown in blue. When you look at the surgeon level, what you see is that almost all surgeons do one or the other. There are hardly any surgeons anymore who bridge the divide between open and robotics for prostatectomy. And the vast majority of these are done robotically. And the truth is, the surgeons who are still doing the open operation are doing a relatively small amount of the total number of cases. So at least in prostatectomy, robotics is here, it's highly prevalent, and the question is, has it achieved the promise that we hoped it would? And I'll discuss that a little bit more moving through the rest of the talk. But what about more broadly in cancer? This technology emerged, and just like with radiation, there's an idea that perhaps we can apply this to an ever-increasing number of diagnoses and tumors and bring this minimally invasive approach to more and more patients. And what I've listed here is just a summary of what's in the literature and what I've spoken with my colleagues both at Michigan and around the country on the tumor sites where robotics is being applied, from urological to gynecologic, colorectal, endocrine, thoracic, and even head and neck, transoral robotic surgery to replace mandible splitting procedures to access the tonsils and the tongue base. So the question is, robotics emerged, it disseminated, it's been adopted in a sustained fashion. Has it achieved its promise? Have the intended benefits of robotic cancer surgery been realized? Well, one way to think about this is to go back 5 or 10 years, and Jim, who will be speaking after me, is one of the most experienced robotic surgeons in our field. And I think if you ask people in urology and outside of urology where they thought robotics might matter, I've tried to show this in 3 different ways. Areas where it was unlikely that robotics was going to offer a clear benefit is shown in red. Areas where it was kind of uniformly thought robotics was going to offer a benefit compared to open surgery is shown in green. And then some of the uncertainty is shown in yellow. So almost no one thought that robotics was going to all of a sudden allow us to cure more cancers than open surgery was. On the flip side, almost everyone thought, at least compared to open surgery, it was going to ease the short-term recovery, get patients out of the hospital and back to their usual activities more quickly than with standard laparoscopy. There are mixed perceptions about the implications for complications. Some people have said, well, you're taking a 2-hour operation and making it a 6-hour operation. There are going to be blood clots, rhabdomyolysis that wouldn't have occurred that's going to occur now. Others said, yeah, but you'll have fewer wound infections and some of the benefits that Dr. Whalen mentioned in his talk. I think probably the most interesting and controversial area is this idea of, can robotics and its better visualization and instrumentation help with functional outcomes? Now, obviously, in the world I live in of prostate cancer, urinary control and sexual function are the holy grail of any treatment we administer. And so the question is, will it help there? And Jim's going to show some new data on that issue in his particular talk. But also in head and neck cancer, there's some thought that this approach may improve swallowing and feeding after major head and neck cancer surgery. So The jury was out on these middle two columns, but there was quite a bit of hopefulness around the short-term recovery and an acknowledgement that cancer control was probably not going to see a huge impact. So what do we know? What have we learned from the literature? What is the state of the clinical science in this area? Well, there are a few randomized controlled trials actually in the cancer literature, and a few more underway. Jim's going to cover these in a bit more detail in his talk. I'll just touch on them briefly. The reality, though, is that most of what we know are from observational studies, some of them very well designed using large population-based data sets with appropriate methods to handle to the extent possible residual confounding and bias in these observational data. But often they're single institution case series, and sometimes the data lack the clinical granularity and the key outcomes. So it's a mixed literature, but it's an evolving literature. In terms of randomized controlled trial, a prominent one in the urology literature was a single institution study from Memorial Sloan Kettering, where about 120 patients were randomized to either open or robotic cystectomy. The primary outcome was major complications within 90 days of the surgery. The key findings were lower blood loss but longer OR time with robotics. Important, but perhaps not the most important thing that patients have in this operation. No difference in length of stay or rates of complications. So no clear benefit to robotics in terms of how quickly patients undergoing removal of their bladder with creation of a urinary diversion get out of the hospital, or in rates of complication. Now, there are many criticisms of this study, and Jim will cover some of those in his analysis. And there's also another large NCI-funded randomized controlled trial underway in this area as well. Sorry, Dr. Whalen mentioned the ROLAR trial, which the preliminary results were just released at the American Society of Colorectal Surgery meeting in 2015. This is a large study for patients with rectal cancer amenable to curative surgery. The primary outcome here is the likelihood of needing to convert to open surgery. Again, this is the idea that robotics is somehow going to allow us to have better ability to deliver on the promise of minimally invasive surgery at a scalable level and not so much at an artisanal level. I'm not going to go into any more of the details here because Dr. Whalen covered some of them and Jim will as well. Importantly, there are two more ongoing randomized trials. The one I mentioned in bladder cancer, that's multi-institutional, led by Dip and Parekh here in the United States, and then a multi-institutional study for robotic versus open prostatectomy in Australia, both ongoing, no data yet available. What does the remaining evidence say? And I could put literally thousands of studies from the literature across these different cancer sites up and give you examples. This is my attempt to humbly synthesize the literature in this area. In terms of robotics versus open surgery, it's pretty clear that as with laparoscopy, it facilitates smaller incisions, shorter hospital stay, and an easier short-term recovery, and that robotics has made laparoscopy accessible to a broader segment of the surgical population, and therefore to a broader segment of the patient population. In terms of complications, the results are very mixed. Dr. Wright, who's here from Columbia, is going to present some of his data on hysterectomy that was in JAMA not too long ago. There are some papers that show fewer short-term complications with robotic versus open prostatectomy. The literature are very mixed. I think it's hard to make any definitive conclusions in that area. In terms of functional outcomes, what the literature that's been published to date, my interpretation is that there is no clear benefit in terms of functional outcomes such as urinary control and sexual function, although there are some new data that Jim Hu will be presenting from a large multi-institutional prospective study that may tell a slightly different story. And at the same time, as I showed in that red column all the way to the left in that earlier slide, no definite benefits with respect to cancer control. But there are a couple key points to make. I mentioned that robotics facilitates laparoscopic surgery. I think this is an important slide in a paper, again, from NYU and Dan Makarov, where they looked at the implications of a hospital acquiring a robot for the use of minimally invasive surgery for patients with kidney cancer. So this was the idea that what we were doing in kidney cancer is many people were removing the entire kidney instead of just the tumor because it was easier to deliver a minimally invasive approach. A minimally invasive partial nephrectomy is probably the most technically complex thing that we do in urology in many ways. What this study was showing was that the hospitals that acquired a robot from 2001 to 2004, by 2005 were doing 30% more partial nephrectomies, and by 2008 we're doing 35% more partial nephrectomies. So there appeared to be this benefit of getting this facilitating technology and getting the guideline recommended or guideline encouraged care to a broader population of patients with cancer. So an interesting benefit in an otherwise mixed set of literature. And then in terms of the short-term recovery, I think the data are difficult to dispute for robotics versus open. And these are, again, data from our statewide collaborative in the state of Michigan for almost 4,000 prostatectomies. When you look at the length of stay and you look at blood loss, it's not even a fair fight. 93% of patients are staying less than or equal to 2 days. Median blood loss is 100 with a much tighter range than you see with the open surgery. So these short-term recovery benefits do exist. But the robot, in my view, is not a panacea, and there are some unintended consequences that have been associated with the introduction of robotics that we ought to consider and think about with great clarity. Many of these stem from the true notion that there was strong consumer-directed advertising associated with the introduction of robotics in urology and in other fields. This happened at a hospital level, and you can see billboards or advertisements like this nearly everywhere. This happened at an industry level. It's seemingly at least once every 6 months there's an article in the New York Times about robotics. And so there were strong forces driving the introduction and adoption of this technology that weren't always harmonized well with perhaps preparedness for implementation of the technology. And that's a challenge that still exists. It was discussed with radiation oncology. It exists with surgical oncology. And it's something that we have to acknowledge and think about. In the last couple minutes of my talk, I'll tell you specifically about some actions we're taking in this area, at least in the state of Michigan. But this is really important because you introduce a new technology in the field of prostate cancer where there's already lots of hand-wringing and concern about the idea of over-treating men with low-risk disease for whom the cancers may have a low likelihood of progressing. And what you can see is that when you introduced a robot, this is a paper from Medical Care in 2011, these are hospital referral regions or geographic healthcare markets that acquired a robot before 2005, ranging from 1 robot up to 9 robots in this hospital referral region. And this is the change in the rate of change in the number of prostatectomies between 2001 and 2005. So clearly, acquisition of robots led to more prostatectomies. One of the key questions here was this just substitution? In other words, were patients who were getting protons now getting robots, or were patients who were maybe going to go on surveillance now getting robotic prostatectomies? So it's that substitution versus expansion question that's really important. And in a related paper published by a former fellow at our center, Bruce Jacobs, this looked at the likelihood of treating men falling in 2 categories, either those with low-risk disease or those who had a high risk of non-cancer mortality based on their comorbidities, with one of 2 advanced technologies, either IMRT or robotic prostatectomy. And this is in a Medicare population, so a slightly older population. But for both of those groups, what you see is this creep toward more treatment of patients with lower risk, potentially indolent cancers. And that ultimately is one of the fundamental issues, because someone earlier mentioned that value is outcomes over cost. And in my mind, it's also appropriateness times outcomes over cost. Because if you do a perfect prostatectomy, but perhaps that patient wasn't going to benefit from it, that's an important concern as well. So this idea of overtreatment is something we have to continue to think about. And there are higher costs. I won't belabor this point. I think you can find a paper that supports your position on the cost of prostatectomy or robotics for prostatectomy on either side of the fence. There is a shorter length of stay, but to get there, you need a huge capital investment in the machine. There are disposables that cost between $1,500 and $2,000 per case. And this, you may start all of a sudden treating more patients, and each one of those adds to the overall purse of how much this procedure costs. This was probably best summarized in a paper from the New England Journal in 2010 that across all these different sites, when you look at whether the standard approach was open or laparoscopic, the overall estimate, and these are slightly old data, but the overall estimate was about $3,200 more per case. So $3,200 more per case from the hospital's perspective. This, I think, is the point that's gotten the most play recently, though. This is this idea of unexpected adverse outcomes as this technology has been broadly implemented. And I know Jim will talk about this a little bit more too, but people have reported on secondary treatments at higher rates, adverse functional outcomes, patient safety events, and deaths that have given significant scrutiny to robotics in particular. And these are 2 papers that were in JCO. One was a SEER Medicare analysis. The other was from a series of surveys sent to Medicare beneficiaries. And if you thought that robotics was going to make a huge difference in functional outcomes in prostatectomy, you would think that you would see better recovery of urinary control, fewer GU-related complications, a more precise anastomosis, a better dissection at the apex, fewer urethral strictures, fewer bladder neck contractures, fewer secondary procedures for prostatectomy. Well, at least in these earlier periods of adoption, there were higher rates of some of these GU complications reported in the literature. And the question is, what do these mean when you measure them in claims data? What are the implications for patient-reported outcomes? And how do we understand why this happened and how we can change things moving forward? So this is the current status within the last couple of years. a huge body of literature on concerns about the implementation of robotics, reflected both in the empirical literature, as shown on the left, and in the lay press, as shown on the right. So where do we go from here? Well, about a year ago, I wrote this editorial with John Berkmeyer, who is a surgeon colleague of mine at Michigan, who's now at Dartmouth. And we thought there's been a lot of headlines and bad press around robotic prostatectomy. Some of it deserved, some of it perhaps less well deserved. But how do we move the field forward? Because if you think back to the slides I showed for Michigan, and the notion that 90% of these cases are being done robotically, and the vast majority of surgeons do only robotic surgery now. The idea that we're somehow going to go back to open prostatectomy on a wide scale, at least in prostatectomy, is very difficult to conceive. So what we've been doing in Michigan and what others have been doing, and this is a study that Jim Hu led, looking at the use of video review to improve the technical quality of robotic prostatectomy. Jim led a group looking at it on surgeons in training, where they were able to show that doing video-based peer review using a social networking page leads to residents who are more comfortable with robotic surgery and more satisfied with the learning experience. Whether this translates into outcomes remains unknown. What we've been doing in Michigan is actually, we now have 35 videos. This is a pilot study of 12 videos. This drafts off John Berkmeyer's paper in the New England Journal of Medicine showing a relationship between peer assessment of surgical skill and complication rates. We've been able to show that if you assess technical skill using validated instruments and fully trained surgeons, that there's a gradation of skill as assessed by your peers, and that actually the surgeons at the lower end of this scoring scale were noted not only by their peers, but also by crowds from Amazon's Mechanical Turk program. I won't go into the details of that, but suffice it to say there's tremendous promise for the ability of video review to identify surgeons that may benefit from coaching or additional proctoring, as Patty mentioned earlier as well. So what we know from video review is that it's feasible. There are measurable differences between surgeons, but what remains unknown is whether these assessments actually correlate with patients' outcomes. Because someone can have to use a baseball analogy, someone can have a really ugly swing but can hit 350 throughout the year. And so those are the things that we really have to still learn. And then finally, how do we use this information? Some people would say you lop off the low performers. My personal philosophy is that from a quality improvement perspective, having a broader spectrum helps you understand the things that matter most in the operating room. So in conclusion, I think there's been a rapid adoption of robotic cancer surgery. No one can contest that. And that its implementation has yielded some intended benefits. More minimally invasive surgery to more patients with easier short-term recovery. Jim is going to cover some of the comparative clinical and cost effectiveness, and we need more work in this area. And then finally, we need to say, if we are going to be doing this operation in the vast majority of patients, we need to not only focus on selecting the right patients, but also thinking about how to improve our technical skills in this area. And at that point, I'll turn it over to Jim. Thank you very much.